and Dr. Pilar Acosta, and but I spend most of my time at the Birmingham VA. When I apologize in advance, my voice is a little off. I'm recovering from a cold, but I'm good. So you already heard about what sarcoidosis is, and basically I'm going to try to kind of reinforce a few concepts that already Dr. Barney and Dr. Acosta mentioned. Is this, you know this well probably right now, it's a disease that causes that these abnormal areas of tissue to cluster in the body, and these clusters are called granulomas. And you know, if many of these granulomas form in any given organ, they can, of course, keep this organ from working properly. You know, if you cluster many of these granulomas in your lung is going to stop functioning well. Same in your liver, same in your eye, in your brain. So it's a problem of these granulomas clustering in different areas. So, like it says in the last line, you know, granulomas cluster in the lung, and the lung stops working well. Now, this is what a granuloma looks like when you look at it in the microscope. This rounded body here. Now, a patient with sarcoidosis will have like millions of granulomas in the lung. So they are microscopic and tiny, but they replace the normal lung tissue. Or they replace the normal brain tissue. So there are no neurons in your brain anymore that are the brain cells. There are granulomas. So you can imagine how people have, for example, headaches, confusion, if it's in the brain, or shortness of breath, if it's in the lung, or basically whatever organ they go to sit up, they basically affect the function and how that organ works. Mm-hmm. So they can go into many of these organs, as you already heard, you know, lungs, eyes, kidneys, liver, heart, skin, joints, muscles, and others. But I am going to try to dwell most on the arthritis part, on the bone part, and try to explain to you how do we approach the issue of arthritis and sarcoidosis, and how do we treat that. So how often do patients with sarcoidosis have arthritis? It's common. It happens at least 50% of the time, if not more than that. Now, it's interesting because I get many consultations from colleagues about patients with sarcoidosis and joint pain, or patients with sarcoidosis and muscle pain. And we check them up, and sometimes it's a sarcoidosis, and sometimes it's not a sarcoidosis. Sometimes it might be another form of arthritis that is affecting a patient with sarcoidosis. Most of the time, it's not the sarcoidosis making a patient causing the joint pain. You know, sarcoidosis can affect your lungs, and you can get short of breath, and you start exercising or walking, and some people can gain weight because of the prednisone or something like that, and then your muscles get weak, and then you start developing this kind of bone-on-bone, we call it degenerative wear and tear arthritis. So we see that quite often. So patients with sarcoidosis have increased frequencies of these bone-on-bone wear and tear arthritis in different parts of the body that we call degenerative. So that's when we assess a patient with sarcoidosis with joint pain, this is what we find most commonly. Now that being said, and this is a cartoon that shows how that looks like, you know, the cartilage that is in between your bones, that's the joint, tends to get degenerated and affected, and that can lead to arthritis in the knees, in the hips, in the hands, and other joint areas. It can become painful, of course. But how often actually do patients with sarcoidosis have arthritis because of the sarcoidosis? It's also common. Probably about up to 25% of patients that come to our clinic with sarcoidosis have arthritis that can be directly linked to the sarcoidosis itself. What forms does that take, or how does it look like? There are a couple of forms that we see. One is an acute form, and one is a more chronic, indolent form. And I'll show you how these look like. The acute sarcoidosis arthritis, as its name probably implies, It's intense, it's acute, happens suddenly. It's usually located in the ankles, and it's usually self-limited. So this is usually a young patient that is healthy, that comes down with acute ankle pain, and the ankle pain can be very intense, very severe, last for a few weeks. It can come along with painful knots in the legs. We call that erythema nodosum. That's the doctor's term for it, but it's a painful area of a painful area under the skin, usually in the legs. Other joints can also get affected. There can be eye inflammation. You'll hear later about eye inflammation caused by sarcoidosis. It can be fever. There can be lung inflammation. The doctor's term for it is Lofgren syndrome. So this is a form that we see sometimes in our clinics. And this is how that ankle arthritis looks like. These are those painful knots under the skin that we call erythema nodosum. The eye inflammation usually is redness, discomfort in the eye, light sensitivity. And we see, and these patients usually come to our clinics. By the time they arrive, sometimes it's going away. Sometimes they just require a short course of steroids or anti-inflammatories like Aleve or Advil, and it tends to go away, tends to have a good prognosis. That is what we call acute sarcoidosis. Probably most of you have not had this problem, otherwise probably wouldn't be here. This is the form that we see in our clinics more often because patients the persons that have chronic sarcoid arthritis are the ones that actually stay in our clinics. Chronic sarcoidosis arthritis can take a number of different forms. Remember, these granulomas, these little granulomas tend to invade and replace a lot of the normal joint tissue, the tendons, the bone around the joints, and it can give you swelling in your fingers. It can give you joint pain and swelling in few or multiple joints. We call this arthritis. When it's multiple joints, we call it polyarthritis for multiple joints. It can affect the tendons around the joints, and it can give you this tendinitis. And it can also replace the normal tendon tissue. And when it replaces the normal tendon tissue, the granulomas destroy the tendon, then the joint gets deformed. And we see sometimes patients coming with these joints that look like they are jelly, that they have deformities and they have very little support and they don't function very well. So they have these joint deformities, not necessarily with joint pain. Sometimes it doesn't hurt, but it certainly to some degree affects the joint function, the structure, and destroys the joint. So this is what it can look like. You see this swelling in the fingers, these fingers swollen, swollen. So it can look like that with that swelling in the fingers. This is what I'm talking about that joint deformity. I had a number of patients with these, that the tendon tissue got replaced by these granulomas, and they have these kind of fingers that are deviated or crooked to the side, and they have these kind of deformities that their hands don't work too well. So how do we diagnose it? The patients come to us, we talk to them, we ask them how did it start, we get a history, and we examine them, and based on our prior experience seeing patients with sarcoid for many years, we can kind of diagnose. Sometimes this acute sarcoid arthritis I told you about doesn't require any more testing. We just talk to the patient, we see them, we examine them, and that's what you have. We have a very clear idea about that. But quite often it's more complicated than that. So we need to get radiographs. We need to get an ultrasound of the joint to see where the inflammation is, what is being affected. We need to get a bone scan, and or we need to get, like Dr. Acosta mentioned, a PET scan, or we need to get an MRI, or we need to get biopsies of some different organs, or we need to look at other. Sometimes sometimes somebody comes with joint pain, and I have to get a chest X-ray to look if they have like enlarged lymph nodes. You already heard about that either not. So this is, for example, when we get an X-ray and a patient comes with bad sarcoid arthritis, you might be able to see these This is how the normal part of the bone looks like. It should be like calcified and white and pretty. All this kind of dark thing is all these little microscopic granulomas replacing the normal bone tissue there. Same up there and up there. So the granulomas can completely invade the joint and bone tissue. And this is a picture of a bone scan that we use sometimes to look at how the inflammation is going. It should be like this, like nothing should light up majorly. And you start seeing how dark it is here, here, here. So all these dark areas around the knee, for example, is where the granulomas have invaded that bone and joint tissue. And sometimes we use tests like that to confirm to know what's happening. So how do we treat it? How do we approach it? I mentioned to you initially, the majority of patients with sarcoidosis, we find that might not be the sarcoidosis that is causing the joint pain, might be some wear and tear or degenerative arthritis. So if that's the case, it's a lot of coaching and self-management. We tell them it's good that you try to lose weight if you can. It's good to try to exercise if you can. It's good to protect your joints through physical therapy or braces or some other strategies. Medication when we need to use it, injections when we need to use it, and sometimes even patients come with stages so advanced that we need to refer them to our orthopedic surgery colleagues. So this is how these treatments can look like. We can inject the knee or the other joint that is painful, or we can send them to physical therapy, or medication plays a role too. We always try to minimize it. Many patients with sarcoidosis already come on a number of medicines for their other chronic medical conditions or for the involvement in the lungs. So we try to always minimize the amount of medicines that they take, but sometimes we need to offer something else. So if it's an acute sarcoidosis, it's mostly self-limited, but anti-inflammatories can help us. Other medicines like plaquenil or steroids, used in short courses, can be helpful too. I'll talk more about this when we get to this part, the chronic sarcoid arthritis. So what do we use for patients who have chronic arthritis caused by sarcoid? So sometimes anti-inflammatories is all they need. Medications like Aleve, Advil, Movicor, meloxicam, or similar medicines. Sometimes other anti-inflammatories like prednisone, which is more complicated, needs to be used. We always try to use steroids in the minimal dose possible. And if another medication can replace the steroid, we try to go there, because many of you may have heard about how complicated they are. They can decalcify your bones. They can predispose patients to diabetes. They can predispose patients to infections. So we always try to give the lowest dose possible of the steroid. And if something else can replace the steroid safely, we try to go there. Patients with chronic sarcoid arthritis will also refer to physical therapy. It's very important. Patients sometimes are very skeptical about this part, or sometimes it's very difficult to commit the time to therapy. But if you have bad joints because of sarcoidosis or because of anything else, reinforcing the muscle and tissues around it, it's very important. It's very important to be as strong as you can be. That is going to support you, that is going to preserve the function of your joints. So other treatments are sometimes where we go to. You already heard about medicines like methotrexate, azathioprine, or Imuran. These medicines suppress the immune system to some degree, not completely, but partially. They tend to get rid of many of these granulomas and can replace the function of the steroid. They have side effects, but it's a joint partnership between us and the patient to see if they can tolerate the side effects, and we can safely use them in some cases. Medicine called hydroxychloroquine is commonly used by our pulmonary colleagues. We use it a lot for other forms of arthritis. And finally, the biologicals that are not FDA approved for sarcoidosis. There's always a fight with insurance. They are very expensive. But sometimes in severe cases of sarcoidosis affecting the brain, affecting the eye, affecting critical organs, we have to go there very, very early, because they are quite effective in many cases. And what can you do? You try to keep a healthy weight, always help. Try to exercise regularly, always help. Always tell us about your joint pain issues and let us know what's happening. Try not to internalize it or to tolerate it. Just let us know. Be compliant with your treatments. And when a treatment doesn't work well for you, methotrexate gives you a lot of nausea, or something else gives you a lot of GI discomfort, let us know, and we'll try to find another alternative for you. So just let us know and we'll work with you. So that's all I have for you. And,